Okay, so I love this stuff, and I love this about being a tissue viability nurse because it really plays to sort of my inquisitive, detective, problem-solving nature, and that is exactly what holistic assessment about. It's information gathering. You've got this wound, or this situation, and you need to know exactly what's going on there. Why is this situation happening, and what are the contributing factors sort of like to it? So when somebody's got a wound, it's not just enough to look at the wound and go, hello, wound. You've got nasty sort of dead tissue in you and bacteria. I need to deal with that. You have to look at the whole patient. You have to look at everything that's going on for them if you're going to get to the bottom of what that wound or that situation, how it's come about in the first place, why it's not resolving, or better still, if you're doing a decent holistic assessment right at the beginning, trying to identify if there's any reason why this wound won't heal in a timely manner. So you're being a real detective, and you have to look sort of like far and wide. There is a great bit of guidance, which I'll just go back a couple of slides. You can see on the beginning here. So Wounds UK is a fabulous website to use, and it does lots of best practice guidance. And this Improving Holistic Assessment of Chronic Wounds came out in 2018. All very readable, all very British, all totally, Wounds UK, all totally applicable to your practice. So just Google Wounds UK into the best practice statements and you will find that there, and it's a good read and pertinent to you guys. So do have a little look at that. I like this bit that it describes holistic wound assessment. It talks about it as emphasising the need for a wide-ranging assessment that considers the impact of all aspects of the patient's health and well-being on the healing process, and the importance of resisting the temptation to make the wound the sole focus. So try and stop yourself from just thinking wound, stand back and look at the whole patient. And it's important because you need to make sure that you're getting the right treatment, that it's in line with best practice, and that you're actually going to be achieving your goal, which is healing. Okay, so a little bit about wounds, why it's so important. It's massive in our working world. You see an awful lot of them. You don't need me to tell you that. But there was a great study done. You must have heard of it, I would have thought. It's called the Burden of Wounds Study by Guest in 2015 and updated in 2018. And they looked at all the GP records to get an idea of how many wounds there were in the country, how many leg ulcers, how long they were taking to heal, how many had had an assessment and all of the rest of it. And what they discovered was that, I mean, this is the data they took was in 2012-13, that there were 2.2 million patients treated that year with a wound at a cost of 4.5 to 5.3 billion. So it's huge cost to the NHS. A leg ulcer in a year, £7,600, and that's one that healed in a year. They also found that 30% of wounds had no diagnosis. So if you don't know what sort of wound it is and you haven't diagnosed it, how on earth are you going to do the right things to get it healed? Of legs, they found that only 41% of those wounds were legs, but of those, only 16% had had a Doppler. Worryingly, 81% were then in compression. So actually, we got a lot of wounds. They cost a lot of money. If we're not assessing them properly, how on earth are we going to get them healed and in a timely manner? And it's holistic assessment is the key to all of that. And the advantages are not just for us, they're obviously for the patient, you know, improved healing rates, reduced physical, emotional and socioeconomic impacts, huge benefit to us. I mean, none of us have got enough time to do our jobs. You don't need a wound sitting there for a long period of time. The quicker you get it accurately and properly assessed, the more likely you are to get it healed. They'll be off your caseload, causing you less work and causing the NHS less money, costing us less money. But also, you know, we all like to do a good job. And when you get a wound healed, I spoke to somebody in Abingdon the other day who said, oh, you know, that lady that you did that strapping technique on that's had her ulcer for goodness knows how long, nearly healed now. I was whooping and skipping down the street. It really made my day, especially after the difficult patient visit I'd done. So if you're like me, when you do a good job and you get good results, you feel better about it, and also your patients do too. So lots of motivation there to do a decent assessment. Right, we don't want you to get too wound up about these terms, intrinsic and extrinsic factors, and we did talk about whether we were going to mention them or not. And we are really only mentioning them because actually in my head, and as a checklist, if you like, when you're doing an assessment, I find it quite useful to think, right, I need to think about the whole patient. And for me, I split that into intrinsic and extrinsic. And intrinsic is just things that are within the body. So that would be, you know, existing diseases, diabetes and all the rest of it. And extrinsic are things that are outside the body. So that it would be more things like lifestyle choices, things that the person chooses to do, like smoking or eating or exercise and the like. So it's purely as a more of an aid memoir, really, when you're thinking about, I have to do a holistic assessment. I need to do the diseases side inside the body, and I need to do the lifestyle sort of things there. So don't worry about trying to work out which is which. So I'm going to go through some of the key things, intrinsic things that happen within our bodies that can impact on whether people get a wound, how well they heal, whether you're going to get delayed wound healing or not, and the like. And these are sort of common to all wounds, really. We are going to have a little look at the sort of key things of leg pressure and edema and things afterwards. So one of the key things is age. Over the age of 65 puts you more at risk of having a wound. Your skin is less robust. But also more at risk of delayed wound healing. Anemia is a classic one. You know, if you're anemic, you haven't got enough hemoglobin to carry as much oxygen around the body, so you've got less oxygen that's been carried to the tissues. And you might want to consider checking a full blood count to see if somebody's anemic for that. Classic chronic conditions that impact on healing, comorbidities such as respiratory things. So somebody's got asthma, COPD, and they've had it for many years. They may have lower oxygenation levels, and they may find it more difficult to perfuse their tissues. Chronic kidney things. What do your kidneys do? Your kidneys excrete fluid from the body. They also excrete some waste products from the body. If they're not working properly, then you can get some buildup of those. And likewise, the liver. Your liver metabolizes things. If it's not working well and it's not metabolizing stuff, you can have a buildup of various things that can become toxic in the body. Immunosuppression, quite clearly, whether that's through an illness or through drugs. If you haven't got a good immune system, you're not going to be fighting infection, and we all know that bacteria love wounds and they delay healing. Cognitive impairment, if you don't understand what's going on, you're less likely to be able to concord. You might be taking your dressings off, you might not be sleeping in bed at night, and the like. Having had a previous chronic wound puts you at risk of another wound and it not healing properly. Acute illness, so you're pyrexial, you've got something else going on, wise, your body's trying to heal that. It doesn't have the resources to heal a wound. And radiotherapy, quite a nasty thing, and that can prevent wounds from healing too. Classics, biggies in the wound healing side of things. If you're looking at somebody's medical history and they've got a wound and you see diabetes, that's a big red flag. High levels of sugar in the bloodstream don't make it easy for wounds to heal. There's all sorts of complex sort of things that happen in the chain of wound healing. You know, the phases of wound healing that you have, of clotting and then inflammation and the like. All of those processes rely upon certain cells doing certain things, and diabetes can interfere with that chain of events, with the neutrophils and the role that they play in wound healing. So it can sort of block the wound healing slightly. High sugar levels in the blood and therefore sort of in the wound bed make it a perfect place for bacteria to grow. And we've included these two pictures here. Sarah Gardner used to talk about this on her leg ulcer study day, because it's a perfect demonstration of how getting diabetes under control can help a wound. So this was somebody with a very complex leg ulcer that was referred to the Tissue Viability Service. Everything had been tried, all the right compression, you know, all the right stuff. Oh, excuse me, I'm going to cough. But they had uncontrolled blood sugars that were really quite high. And the GP was very reluctant to start them on insulin, thinking that they wouldn't cope and they would need various support strategies. Anyway, because the wound wasn't healing, they did go ahead and put in a package of care to try and make the administration of insulin possible. And that was the impact on the wound. 8 weeks after starting insulin, the wound's healed. So, you know, you cannot underestimate how the impact of something like diabetes can have. So you need to be assessing how well that is controlled and doing something to improve that. Circulatory disorders, they're another biggie. So arterial disease, In the body, you will see signs and symptoms when you're looking in somebody's medical history. If somebody's had an MI or angina, TIA, CVA, history of intermittent claudication or grafts of some sort, you know that they've got disease in their arteries. What do arteries do? They bring blood with oxygen and nutrition to the body. If you've got narrowing, you're not getting as much oxygen and nutrition to the cells, then the wound can't heal. Venous wise, it's more of an issue really with legs than any other part of the body, but you'll know that varicose veins, things like lipodermatosclerosis and oedema, sclerotherapy, if you're seeing those sorts of things in the medical history, you know this person's got venous disease, and you know that any wound on that leg isn't going to heal properly. And people with heart failure, you need to be careful with that in many ways. So that might also tell you that this person's got some arterial disease. Sometimes heart failure is as a result of people having had MIs, but also it means that maybe people are more prone to edema in their legs, and that can be something that can delay healing too. So all of these things will be important things that you're looking at for in people's sort of medical history. Autoimmune diseases are a biggie when it comes to wound healing, so we've lumped it all into one really. But if you've got a disease of your immune response, and your immune response is key to the phases of wound healing, it's not a giant leap to think, if that's not working right over there, it's going to interfere with wound healing. And there are loads, there's something like 80, I didn't realise, autoimmune diseases. So big ones that we know of are rheumatoid arthritis, lupus, MS is an autoimmune disease, psoriasis, and they can all impact on wound healing. Some of the gut ones, like Crohn's disease and ulcerative colitis. Scleroderma is an autoimmune disease of the connective tissues, and that can obviously impact on wound healing too. Not just on wound healing. When you've got an autoimmune disease like this, you are also more at risk of some unusual wounds, things that don't look quite normal. And there's a couple of examples here. So vasculitis, which is the leg with all the purpley bits on it, not always on a leg, it can be elsewhere. I've seen it up thighs and on arms and all over the place. And that can break down and almost look necrotic. And what that really needs is steroids, but you'll need onward referral to a specialist for that. And then the other picture on the right is pyoderma gangrenosum, and that can be, so if people have got an immune disease, they can be more likely to have something like this. So if you see a wound of an unusual presentation, make sure you're checking somebody's medical history to see if they've got some sort of autoimmune condition, because that might give you a really, really big clue. If you're getting that, you might be wanting to speak to the GP and saying, I think this is something related to their inflammatory disease. Do we need to check inflammatory markers? Do we need to refer back to immunology? Do we need to even consider, if this is a pyoderma, sending somebody to dermatology for a biopsy, and the like? Do contact us for some advice if you need it. So they're a big one, don't miss them out. Medications, they can impact on healing. So steroids, they reduce inflammation. Of course, that goes to say that they would interfere with the inflammatory stage of wound healing and disrupt things. Some significant drugs, chemotherapy-wise, so people with methotrexate, hydroxychloroquine, that's the thing that Donald Trump is taking to try and stop himself from getting COVID. Puts him at risk of a wound that won't heal properly, one can only hope. Sulfasalazine, so chemotherapy type things, they can make wounds more difficult to heal. Anticoagulants, warfarin, apixaban, they can interfere with the clotting stage of wound healing. Immunosuppressants, clearly, and non-steroidal anti-inflammatories. They also have an impact on inflammatory bits that can interfere with the inflammatory stage of wound healing. So possibly not the best analgesic to be using when you have a wound. So I'm just going to let Lauren start talking now. I will mute myself, Lauren, so that I don't interfere with you, but I am listening, and just tell me to move the slide on if you need me to.
Lovely, thanks, Penny. Okay, so Penny's gone through a bit of the intrinsic factors, so looking at what's going on inside the patient's body with chronic diseases and medications. Like we said, don't get too hung up on intrinsic versus extrinsic, but the things that I'm going to be talking about in the next few slides are the extrinsic factors, so patient choice really, things like their lifestyle, which we're going to start with. So things like smoking is a big one. For every one cigarette that a patient smokes, that reduces blood flow for 20 minutes. So that causes vasoconstriction for 20 minutes. So for example, if you've got a patient smoking 20 a day, that's 7 hours of reduced blood flow, and that could be reduced blood flow to that wound. And as we know, that blood flow is vital for healing. So trying to encourage our patients, I know it's difficult if someone's got, you know, a long smoking history, but smoking cessation advice, just anything really that, you know, that we can do, even if they're cutting back, because for, like we say, for every cigarette, that has a huge impact on the blood flow. Nutrition is a biggie, and it's what I'll do a separate module on. So I'm not going to go through it in too much detail, but as you've probably heard us discuss on study days and when we've been speaking to you out there and giving advice, for any patient with a wound, they do have an increased need for calories and protein. And so to give you context of that, we ordinarily require 1 gram of protein per kilogram of our weight, and that's just normal. That would be what we would be looking to achieve normally. For a patient that then has a wound, that increases to 1.25 to 1.5 grams of protein per kilogram. So that is quite a big increase, especially with these patients who may not have a great diet anyway. And if we were actually to look and break down exactly what they were eating, they're probably not getting the minimum requirement of protein to begin with. So the fact that they then need that increased protein for healing is really, really key. Again, we'll go through it on the module in more detail, but things like just asking them to do a food diary to really be able to look at how much protein they're actually getting, and ways of fortifying is really, really important. And for pressure damage, particularly, it's the second most important thing you can do is increase their protein, and that's second importance to offloading the pressure. So it is a big thing. Okay, Penny, if you go to the next one for me. Thank you. So yeah, other extrinsic factors would be psychosocial factors. So this can be understanding and mental capacity. So Penny did touch a bit on it earlier about cognitive impairment. But if the patient doesn't have an understanding of their wound, of what's going on, or if they lack capacity, it may be that you then get problems with them sort of being concordant. They may take dressings off because they don't understand. So I think really, if a patient has the ability to understand, and if they're accepting of that information, it's really important to try and explain what is going on underlying, so that they can appreciate why they may need to make certain changes, why you're trying to implement a certain care plan. And it does really go a long way to do that. It can be more difficult in patients where there is cognitive impairment and there's nothing, you know, that we can do about that. But it's, you know, picking up on signs, you know, are they taking dressings down because they're distressed and they're in pain? So it's just thinking about those things. That also links onto concordance, which is a huge thing, which Penny is doing a separate module on, concordance and motivational interviewing. And it's just looking at techniques of getting the patient on board. I think non-concordant is a really easy label to give a patient. And I think it's just about getting to the bottom of why they're presenting in that way, because, you know, you ask a lot of patients, I'm sure that their goal is not for their wound to be there forever. I mean, maybe there might be in the odd occasion, but for most people, they, I'm sure, as much as you, want their wound to heal. So it's trying to get to the bottom of maybe why they're not on board with certain plans, and how we can negotiate and how we can get around that and around those barriers. Social and healthcare needs, that can impact as well. It might just be to do with the level of care that they need for certain interventions. It might be that they actually lack that care and social support, and you know, if you're picking up on that, it's being able to flag that and get that in place for them. Simple things like they need hosiery, but they don't have family, they're unable to do it themselves, and they're currently not being seen by carers. So things like that, just to be able to get over those barriers. Financial and employment, things like employment in terms of the legs, for example. So there's certain occupations where their legs are more at risk if they're stood for long periods of time, or if they're sitting with their legs down all day. That could be a big impact on their legs, or why they're suffering with ulceration now, or if there's any financial barriers to them having certain treatments, that can be a problem. Psychological and relations status. So again, mental health wise, it might be that they are suffering awfully with their mental health, they're very low in mood, and that might make them difficult to understand and be on board with treatment, but also just to have the motivation to be on board as well. Because if they're mentally not in a good place and they don't have that support around them, it does make, you know, their priorities are shifted, or their motivation, you know, to actually be on board with you is going to be shifted. So it's thinking about, do we need to look at their mental health first before we come in and start looking at that wound and how we treat that. Cultural and religious beliefs. Again, it might just have a certain impacts on the care plans that we're trying to have. So it's just asking them really, or, you know, being respectful of what those cultural religious beliefs may entail, and trying to tailor any care plans around that. Same goes with health beliefs. You know, a patient is very much entitled to consent or not to certain treatments. So again, it's, you know, working with them to see what would work best for them. Major life stressors. Yeah, again, it's kind of linked with mental health. If they've got a lot going on in their lives, and there's something that's particularly stressful, it may just be that at that time the wound is not currently the priority for them. So it's thinking about what else is going on with that person, and how can we sort of offload the pressure from them in that way to allow us to help them in the way that we want to. Isolation. They may not have social support and carers, again, like I touched on earlier, and also your relationship with them is key as well. And I think that does link in quite a lot with concordance, which Penny will talk about when she talks about motivational interviewing. But I think name nursing is a great thing, and being able to build a rapport with that patient. You've both got a level of understanding. You're also able to recognise, and you know that patient well enough to know something else is going on here. They may be deteriorating in health. It may be that you've noticed their mental health, or something socially is going on that needs sort of managing. So it's really key. You know, I know in an ideal world we'd always say name nursing, and I know it's difficult, but trying to build that relationship at least between a couple of nurses so that we really get to know our patients. Other factors that are big ones. Pain is a key thing. Again, links that these all intertwine with each other. This can link in with concordance. It could simply be that the patient isn't on board because they're finding something particularly painful. So it's thinking about how we can get on top of that pain. There is on our website, there's a under wounds and then blank documents, there is a assessment tool for pain, which I did this work on, and it's specifically in regards to wounds. So it does look at your normal pain relief, and looking at the different, being able to recognise the difference between nociceptive and neuropathic pain, and the treatment methods for those, but also dressing methods to help reduce pain as well. So if anyone is wanting to look at a specific tool regarding pain and wounds, that is on our website. Mobility and activity level, big ones, not just where legs are concerned. So our patients who may be just sitting with their legs. Yes, Penny, thank you. She's saying the pain assessment's on the resources tab and blank documents, not the wound tab. But mobility, yeah, so it may be that the patient has their legs down, dependent, and they're suffering with chronic edema, or it could also be that their mobility means that they're more at risk of pressure damage. So that's a key thing. And also the environment and the hygiene as well. So are they in an environment where they're quite unkempt and there's potential for lots of bacteria, and there are high risk of infection. So, and also feasibly how easy it is to do our dressing changes. Is the house very cluttered? Are we short of space? Thinking about all those things that could impact. Okay, back one, Penny, you flick to. Lovely. Penny went through this a little bit when she was talking about circulatory disorders, but what we have chosen to do for these slides, everything we've spoken about so far is looking quite generally with any patient with a wound, but we are just going to try and pick up on a few key things that you would want to be looking at in terms of your holistic assessment for specific conditions. So for example, when we're looking at legs and you're doing your sort of your lower limb assessment, your Doppler, a key thing is looking at their history as well. So key factors for them having and pointing towards venous disease would be history of DVT, thrombolysis, leg, pelvis or foot fractures, vein surgery or sclerotherapy, obesity, someone who's had multiple pregnancies, or history of a pulmonary embolism. And you can see there a nice picture of a very, I'm sure all these are not this straightforward, all these legs we see out there, but a very, very clearly venous leg. And arterial wise, again, I'm afraid I couldn't find an arterial leg. I had to find an arterial foot instead. But key things, again, that would tie in with your lower limb and your Doppler. But key things you'd be looking for in their history would be intermittent claudication, ischemic rest pain. They may have had a CVA, an MI, a TIA, history of peripheral vascular disease, maybe in a long-term smoker, they have diabetes, heart disease or previous heart surgery, hypertension or renal disease. And I'm going to hand back over to Penny to talk about pressure specifically.
Thanks, Lauren, that was great. Okay, so yes, on top of the general things that we've been talking about for pressure, there are specific things that might be ringing bells and things that you would be looking for within somebody's medical history and part of their holistic assessment. And some of this sort of, you know, I was saying earlier on when I've got a mental thing about assessment, what do I need to do? And I'm thinking, oh, whole person, intrinsic, extrinsic. When it comes to somebody with a pressure ulcer and I'm thinking, what do I need to think about? I think whole person, intrinsic, extrinsic, and then I tend to think skin bundle and go through surface skin, keep moving, blah de blah. And between those two things, you tend to get you cover all of the areas that you need to for a pressure thing. So some of these are kind of within the skin bundle side of things, but anyway, so all the diseases and intrinsic, extrinsic factors we've talked about so far. As Lauren said, nutrition when it comes to sort of pressure, in preventing pressure damage and also in managing pressure damage. So a really good assessment of what their weight is, have they been losing weight, what their BMI is, what their must score is, sort of vital, a decent must score, because that's so strongly linked between whether somebody has pressure damage and whether it heals or not. So you need to be really looking at their nutrition. And if you see somebody with a BMI of 18 already, I don't have to see the patient. I'm already thinking, uh-oh, at risk of pressure damage here. So other things you need to know: previous pressure damage puts you at higher risk of that. So a history of that would be a warning bell in your mind. Mobility, immobility or poor mobility, how they mobilise. Seating, posture, positioning and posture, absolutely massive. It wasn't until I joined the team and I had to work with Sarah Warner, which sounds like a bad thing, but it wasn't. It was a rather marvellous thing. And she's so focused on posture and the impact that it has on your risks of pressure damage that I've learnt loads. So looking at somebody and their posture in a chair, if you know somebody sort of got some sort of muscular disease, for example, like MS or motor neuron disease, you would imagine that they're not going to be able to hold themselves up straight. So as soon as you know that, you'd be thinking, oh, somebody with this sort of history is likely to have postural issues because they haven't got the sort of control of their muscles. So thinking about posture and how people move. Care environment, really important. Has somebody got help to move, somebody got help to care for their skin, and somebody to be able to observe pressure areas, so assessing care environment. Medical devices and equipment, anybody needing to have oxygen, that's always a biggie because straps around your ears are likely to put you at risk of pressure damage there. So people with you know, home oxygen, you'd need to be thinking about that. One, they're going to have poor perfusion because of their respiratory disease, and two, they're going to have rubbing around their ears, two big risk factors that put them at risk of pressure damage. If then, because they can't breathe properly and they've got an oxygen mask on their face all the time, they haven't got great nutrition, then they're getting even more risk of sort of like pressure damage. So have they got any medical devices or equipment that they're using? End of life, obviously, the last few days of life, your skin is like any other organ of the body. As you begin to sort of your body begins to shut down and divert the circulation to the core organs of the brain and the heart and the like, your skin gets less oxygen and you're more likely to have pressure damage. Yeah, that's not just palliative. Oh, this person's now palliative, so whatever pressure damage they get is going to be scale. That is, you know, your organ, your skin is being deprived of circulation in the last few days of life. Manual handling, transferring techniques. If you know that people need help with that, you know that you're going to have issues, potentially risks for pressure. And extremes of age, really, you know, very old skin, as we've said, or, you know, over the age of 65 puts you at more of a risk of having a wound and it not healing well. But also very young skin. Very young skin is not as strong as mature skin. Key things for chronic edema. So on the chronic edema day, apart from the things that we've already talked about, there are some other key things that we talk about in holistic assessment. So particular things in medical history to ring bells when it comes to chronic edema would be anything that would cause edema, really. So if you think about the different causes of edema, you could have primary lymphedema, you could have secondary lymphedema from things like cancer. So if you've had breast cancer and any surgery that's been interfering with your lymphatics around there, that could put you at risk of sort of lymphedema, chronic edema. Interchangeable words, by the way. If you've had lymph node biopsy, that could cause a problem with your lymphatics and cause chronic edema. Heart failure, we know, can cause chronic edema. If you've got, you know, nasty end-stage renal disease, you're not kicking out the fluid, it's staying on board. If you've had surgery, so sometimes people who've had surgery around their groins, that's interfered with their lymph nodes and lymphatics there. Radiotherapy can do nasty things to places and cause sort of chronic edema. And arthritis, so rheumatoid arthritis, I'm not just talking about legs here, but in joints and arms, that can give you chronic edema too. The biggest one that we know of, a cause of edema, really sort of district nursing wise, is the good old venous disease that's been there for so long and the person's got less immobile and other comorbidities that they've now got lymphovenous disease. So it's not just venous disease, they've started to get edema in the leg. So if you're looking through somebody's medical history and you're seeing that they've got a history of venous disease, varicose veins, sclerotherapy, often GPs, they seem to like this word, lipodermatosclerosis. So you seem to see people diagnosed with that. You might see edema or dependency edema sort of written in somebody's notes. Medication, big one for edema is amlodipine. It can cause edema if somebody's on amlodipine and has edema, and we would suggest you speak to the GP about whether they can be changed to something else or whether that dose can just be reduced from 10 milligrams down to 5. That have a significant reduction in the edema there. You particularly want to know about family history. Has anybody in their family had edema before? Venous disease can be familial, cardiac issues and renal issues. Obesity, obviously people with obesity are more likely to have edema. They've got far more weight pushing down on their circulation coming back from their legs to make venous hypertension a reality there. And immobility and dependency. So you've got somebody sitting for long periods of time with their legs down, maybe somebody wheelchair bound, or people not moving, they're not getting their calf muscle pump going, they're going to more likely to get edema. And you need to know where somebody sleeps. I should have put it at the top of the list really, because, you know, if somebody's not sleeping in bed, that is a massive risk factor, and that would stick out as a big red flag for me. Yeah. Okay, Lauren is going to take over now.
Lovely. So we've obviously gone over holistic wound assessment, intrinsic, extrinsic factors. We've touched on sort of the key things you're seeing out there: legs, edema, pressure, and key things we'd be looking at. And you're probably all thinking, well, how do I even go about starting a holistic wound assessment? So we'll talk to you about kind of what we do within our team as well when we're helping clinicians. But the first thing we do is we would suggest you go on EMIS and print out your patient summary. So with that, you want to be checking their past medical history, looking at what medications they're taking and any allergies they may have, and then just going through really. So you can refer back to this as a resource, but picking out those maybe key chronic diseases they have and how that could impact on their wound healing, or key medications that could be interfering as well with wound healing. Baseline OBS is always a good one, looking at are there, in terms of infection, are they a sepsis risk, are they hypertensive, and is that being unmanaged? So that's always great. Bloods, we always usually try to ask for recent up-to-date bloods. So again, check your patient's bloods. Have they had recent bloods? We usually say full blood count, USANE, CRP, a HbA1c, and LFTs. So key things we'd be looking at is the patient anemic? What's their HB? If they are anemic, is this being being treated? Is it not? Do we need to flag with the GP? Yes, they're anemic. Why is this not being treated? Sometimes some of the GPs have a tendency to say that they'll just sort of monitor it, but I think if they've actively got a wound, we need to be encouraging them to be treated for their anemia, because it is going to have a huge impact on the healing. Their renal function is another one we look at. Any signs of infection, so CRP, diabetes control, so with the HbA1c, and also low albumin. It's not an absolute true picture, but we look at albumin, and if there's low albumin, it can give an indication that they've got poor nutrition. It could also be because they're losing so many proteins and things through a highly exuding wound. But if they have got low albumin, it is thinking about what is their nutrition like. Do ask the GPs if they're happy for bloods to be taken, as it's them paying for it. So please don't go out and just take bloods without checking with the GP first. But usually if you're explaining that you're just wanting to do a screen, they are happy for that to be done. So then after looking at all of that, the next thing that's a really good resource, and I know we don't want to overwhelm you with all the paperwork, another piece of paperwork, but this really is a great resource, and I would really encourage that you use this as part of any wound assessment that you do. You can refer back to it, and it will basically give you indicators. Is this wound going to be hard to heal? So from the get-go. So it's called the Wound Healing Pathway and Risk Assessment. It's on our website. So if you go to the resources tab and then under blank documentation, I'm sorry that it's very small. It's not intended that you can read it, but it's just so you can have an idea of what it looks like. So when you open it, you know it's the right thing. It's basically a flow chart on one side. And if you just follow that, it then suggests, is this wound going to be hard to heal or not? And on the back is like a tick sheet. So you'll kind of make out there's like grey boxes and then the tick sheet. And basically the various grey boxes go through all of the different risk factors for healing, and they do include intrinsic and extrinsic factors. It's not an exhaustive list, so if there is anything else you're identifying, but it's a pretty good list that covers most bases. So what you'd want to be doing is looking at your patient, talking with your patient, thinking about their wound, and then thinking about their past medical history and all that stuff, and them socially, and going through that checklist. So it's basically just a prompt of, is this a risk factor? Is this something that's happening with them? Ticking yes. The more ticks you have, the more risks there are that this wound is going to be hard to heal. So it's just trying to take that focus away of not just looking at the wound, what tissue you've got there and how you're trying to treat that particular wound, but also what else is going on with the patient that's going to make this difficult to heal. Other assessment forms, again, not an exhaustive list, but things that will tie in and be more important depending on what wound you're looking at. But of course, you'll for district nurses, you'll have your initial assessment form, your DN assessment form, pressure damage risk assessment and Braden, obviously key for pressure, nutritional assessment and a must, really key for all wounds, so not just pressure. Skin inspection and assessment, lower limb assessment, particularly for legs, pain assessment could be important for all aspects, and continence assessment may tie in with your pressure and just your general skin, or if they've got moisture problem as well. Quality of life wound checklist is another one. I don't know if you will have seen it, but it is on our website also, on the resources tab. But basically, it's just looking at your patient and their sort of feelings and thoughts on their wound. So it's trying to think more about your patient's sort of psychosocial aspects, and looking at the quality of life for them, and it'll just help you to pick up and identify things that perhaps you could amend or change, and improving that patient's quality of life, which in turn may improve their concordance or their ability to be on board with your management plans. It is, again, it's another form, but it is a really good key thing that I think picks out important things that maybe would go amiss, because we are so focused on potentially their disease processes or their wound, and it's just thinking about how, you know, their feelings and their sort of social aspect of the wound.
So this is my slide at the end. This is the last slide, and it's just to say, just to try and encourage you to be excited about this aspect of care, because when you manage to get a good assessment and you know what's going on, your care will be better and you will get better outcomes. And it's a marvellous thing when you heal a wound. But I would also like to say as well that it's not just about your initial assessment. You need to keep coming back to all of this stuff. And the key thing that I would like you to do is to, I think it's been something that's been dropped and absolutely needs to sort of come back in. And that is like your 6-weekly wound mapping thing. Because it's all very easy to do your initial assessment, put your care in place. Yes, I've done that. Off you sail into the sunset. And then, these are dynamic situations. What may be the right care to start with may no longer be the right care 6 weeks down the line. And before you know it, the wound has slipped into just being really quite static. Or you've handed the wound over, having done your marvellous assessment and put your fabulous care plan in place. You've handed over to an AP or a healthcare assistant, and you haven't actually gone back in and reassessed. The 6-weekly remapping and reassessment is a really useful thing, because when you remap and you do that calculation, if you haven't got 40% reduction in that wound, you've missed something. So you need to put your detective specs back on, your silly little hat, and you turn your thingy up, get your spyglass out again, and you need to go back and you need to find the reason why you haven't had that 40% reduction. That's your job, to be that detective. And unless you are being highlighted that this wound is now stalled again, and the only way you can do that really is through that mapping and reassessing and going, oh, we're not getting the healing rate we should, you won't then end up doing that reassessment. So please do become a sleuth. Get your funny outfit out and just try and work out who did it with what and where. So that is the end of our presentation.